Good afternoon, everyone. Myself Taranpreet Kaur, and I'm presenting on the topic gastrointestinal tract, liver, and the kidney. These are the contents of my presentation. Introduction. The digestive system and excretory system work together to process nutrients, remove waste, and maintain homeostasis in the body. The digestive system is responsible for breaking down food, absorbing nutrients, and eliminating unabsorbed material. Major organs consist of mouth, esophagus, stomach, small intestine, liver, gallbladder, pancreas, large intestine, rectum, and anus. The excretory system removes the metabolic waste from the body, maintains water and chemical balance. Major organs constitute the kidneys, ureters, bladder, and the urethra. The GIT, also known as the alimentary tract, is the portal through which nutritive substances, vitamins, minerals, and fluids enter the body. It extends from mouth to the anus. It is more than 10 meters long from one end to the other, plays a vital role in ingestion, digestion, absorption, and elimination of foods and waste. These are the parts of GIT. Anatomy. Mouth is the entry point, helps in mechanical digestion, that is chewing and chemical digestion with help of saliva. Esophagus, muscular tube that transports food to the stomach via peristalsis. Stomach secretes gastric juices, HCl and enzymes for protein digestion, which converts food to chyme. The small intestine, duodenum and jejunum and ileum receive bile from the liver and enzymes and main site for nutrition absorption into the blood. Large intestine, colon, rectum and anus, they absorb water and electrolyte, form and eliminate the feces. Now, these are the parts of the GIT tract in their individual functions. Functions of the GIT: ingestion. It involves placing food into the mouth, mastication, that is chewing of the food, moistening of the food with salivary secretions, deglutition, that is swallowing the food. Digestion. During digestion, food is broken down into small particles and then degraded by digestive enzymes into usable nutrients. Absorption. The nutrients, water, and electrolytes are transported from the GIT to the circulation. Digestion. The undigested food, along with various secretions and slowed off epithelial cells from GIT passed into rectum and constitute the feces, which avoided through anus at periodic intervals. A flowchart of the human digestive system. The food travels from the mouth to the buccal cavity, pharynx, esophagus, cardiac stomach, pyloric stomach, which goes into the duodenum. Bile and pancreatic juice enter small intestine, large intestine, rectum, and the anus. Some of the common GIT disorders are dysphagia, gastritis, gastroesophageal reflux disease, diarrhea, malabsorption diseases such as celiac disease, lactose intolerance, flying loop syndrome, inflammatory bowel disease, ulcerative colitis, Crohn's disease, and amoebiasis. GERD. GERD occurs when stomach acid frequently flows back into the esophagus, causing irritation and discomfort. Symptoms include heartburn, acid reflux, difficulty swallowing, chronic cough, or sore throat. Causes and risk factors: weak lower esophageal sphincter, obesity, smoking, alcohol, spicy foods, pregnancy. Treatment and management: lifestyle changes, that is avoiding trigger foods, eating smaller meals, medications such as antacids, proton pump inhibitors. In severe cases, surgery may be needed. Peptic ulcers are open sores in the stomach lining. Gastric ulcers or upper small intestine, that is duodenal ulcers. Symptoms include burning stomach pain, bloating, nausea, vomiting, dark or bloody stool. This is a diagram of peptic ulcer. Causes and risk factors: infection by H. pylori, long-term use of NSAIDs, example, aspirin, ibuprofen, immunosuppressants, excess stomach acid production, renal failure, stress cause Cushing ulcers, whereas burn cause Curling ulcers, iron therapy, alcohol abuse. Treatment management: antibiotic regimens for H. pylori infections are clarithromycin, amoxicillin, tetracycline, metronidazole, and omeprazole, or H2 receptor blocker for 1 to 2 weeks. Some regimens are clarithromycin, metronidazole, and omeprazole for 1 week, whereas clarithromycin, amoxicillin, and omeprazole for 2 weeks. Ulcer protectors such as sucralfate, 1 tablet is given 1 hour before each meal and 1 at a bedtime. Continued for 6 months. Irritable bowel syndrome or IBS is a functional disorder affecting bowel movements, causing discomfort without structural damage. Symptoms are abdominal pain or cramping, bloating or gas, diarrhea, constipation, mucocystis. Symptoms, as we have already discussed. Causes and risk factors: exact causes are known, but is linked to gut-brain interaction, stress, food intolerances, infections, hormonal changes, which are more common in women. Treatment and management: dietary changes, management of stress through exercise and relaxation, symptomatic relief treatment. Irritable bowel disease. IBD is a chronic inflammatory condition of the digestive tract, mainly including ulcerative colitis and Crohn's disease. Ulcerative colitis is a chronic recurrent inflammatory disorder of rectum and colonic mucosa resulting in ulceration and bleeding, whereas Crohn's disease is a chronic granulomatous inflammation of terminal ileum and adjoining colon resulting in ulceration, stricture formation, fistulation, and abscess formation. Causes: familial and genetic disorders. 10 to 15 patients have a first degree relative with IBD, whereas infective disorders, there is colonization of gut with bacterial overgrowth. Immunological disorders, because of histopathological evidence of inflammation of ball and non isolation of inactive agent, immunological base of disease has been proposed. Cigarette smoking is strongly associated with Crohn's disease but is not associated with ulcerative colitis. The Crohn's disease, diarrhea and pain abdomen in right lower quadrant with tenderness and guarding. A mass may be palpable on rectal and abdominal examination. Moderate diarrhea and fever. Stools are loose or well formed. Patients have anemia, weight loss, growth retardation in children. Crohn's disease give a cobblestone appearance, that is, deep ulcers with edematous mucosa in between them. There are patches involving a segment of ball separated by a normal ball segment, characteristically caused as skip lesion. Now, this is an example of skip lesion. There's a healthy segment separating the affected segment. Treatment management, diet and nutrition, low-fat diet or milk-free diet, oral broad-spectrum antibiotics and metronidazole in presence of infection, supplementation of iron, folic acid, calcium, vitamin D, electrolytes. For diarrhea, diphenoxylate or loperamide. In extensive active disease, prednisolone may be given for 2 to 4 weeks and gradually withdrawn over 4 to 6 weeks. Azathioprine in the dose of 2.5 milligram per kg per day used in patients who relapse on steroid therapy and surgical treatment, that is bowel resection. Ulcerative colitis, it is diarrhea with blood, mucus, and pus. Pain in the abdomen and fever may be present. Tenderness in left side of abdomen or left leg fossa. No palpable mass, no colicky pain. Patient has severe diarrhea with tenesmus. Anemia and weight loss may be present. Malabsorptive features are less common. Polyps and pseudopolyps are present. Continuous with no skip lesions. Ulceration, stricture, and fistula is uncommon. Example of ulcerative colitis. Treatment management, supportive treatment, form of parenteral nutrients, fluid and electrolyte, and correction of anemia. Prednisolone or betamethasone suppositories. Prednisolone given orally for 4 to 6 weeks. In case of severe ulcerative colitis, intravenous hydrocortisone or methylprednisolone is 4 divided doses given. Sulfasalazine for 1 to 2 years. In biological therapies, example anti-TNF therapies with monoclonal antibodies and antidegrants. Surgical treatment is proctocolectomy. Coming on to liver. Location and anatomy. Location located in the upper right quadrant of the abdomen, situated between the diaphragm on the right side and extends partially into the left side of the abdomen. Size and shape. It is the largest solid organ in the body and is shaped like a wedge or triangle. It is divided into two lobes, right lobe and left lobe. The lobes further divided into lobules and surrounded by a connective tissue capsule called as Glissen's capsule. Blood supply. It receives blood via the hepatic artery and the portal vein. Associated structures. Gallbladder located on the underside of the liver stores bile in hepatic ducts, transport bile from liver to gallbladder and small intestine. A diagram picturing the liver, anterior view and the posterior view. Biliary system. The portal tracts contain branches of the hepatic artery, portal veins, bile duct, collectively known as portal triads, and branches of main hepatic lymphatics that drain into portal lymph nodes. The branches of hepatic veins unite to form three main veins which drain the inferior vena cava. The lymphatics accompany hepatic veins. The biliary system consists of biliary canaliculi which join to form small intrahepatic bile ductules. These ducts join to form a common hepatic duct which comes out of the liver and joins the cystic duct to form a common bile duct. The distal part of the common bile duct joins the pancreatic duct before it opens into the second part of the duodenum. The cystic duct of the gallbladder joins the common hepatic duct. Functions. It performs a wide variety of functions such as metabolic, synthetic, detoxification, immunological, maintain normal levels of blood sugar, utilize amino acids for endogenous protein synthesis and plasma protein synthesis, key role in metabolism of drugs and endogenous hormones, important site for hormone action and degradation. Fatty acid derived from diet or adipose tissue are esterified to triglycerides in the liver. Conjugation of the unconjugated bilirubin. Addition to hepatocyte liver contains mononuclear phagocytes. The reticuloendothelial cells are derived from blood monocytes and perform immunological functions. The liver secretes 1 to 2 liters of bile daily, and liver cells provide the driving force for bile flow by creating osmotic gradient. Vitamin A, D, and B12 are stored in large amounts in the liver. The disease of the liver, some of the common diseases are jaundice, hepatomegaly, hepatitis, and cirrhosis. Coming on to jaundice, jaundice or icterus refers to yellow discoloration of skin, mucous membranes, sclera, and conjunctiva due to raised serum bilirubin. Bilirubin is a yellow pigment produced when RBCs break down. Normal level ranges from 0.3 to 1.5 milligram per deciliter, whereas jaundice becomes clinically detectable when the level is reached 2.5 milligram per deciliter. Subclinical jaundice is referred to as when serum bilirubin is raised more than normal but less than 2.5 milligram per deciliter. Symptoms include yellowing of skin and eyes, dark colored urine, pale or clay colored stool, fatigue and weakness, nausea and vomiting, itchy skin. Causes: liver diseases such as hepatitis, cirrhosis, and liver cancer, blockage of bile ducts due to gallstones, tumors in the pancreas or bile duct, increased red blood cell breakdown, example microangiopathic hemolytic anemia, or infections like malaria, neonatal jaundice, Gilbert syndrome, Crigler-Najjar syndrome, cholestatic jaundice of pregnancy, and drug-induced, especially in G6PD deficiency patients. Now, differential diagnosis of jaundice: three types: prehepatic, hepatocellular, and obstructive. Prehepatic: hemolysis leading to excess production. Hepatocellular: deficient uptake, conjugation, or excretion by hepatocytes. Obstructive: deficient excretion due to obstruction of bile duct. Mainly unconjugated bilirubin in prehepatic, unconjugated and conjugated in hepatocellular, and mainly conjugated in obstructive. Urine bilirubin is absent prehepatic, present in hepatocellular, and present in obstructive. Additional features: features of hemolysis on blood smear seen in prehepatic, whereas marked rise of serum ALT and AST in hepatocellular, and marked rise of serum ALP 3 times more than normal in obstructive. Diagnosis: hemoglobin, peripheral blood film, urine for urobilinogen, bile salts and pigments, and stool for stercobilinogen, total bilirubin, alkaline phosphatase, serum cholesterol, SGOT, PT, PTI, and PTTK, ultrasound for liver, CT scan, MRI, liver biopsy, liver disease effective. Treatment for liver-related diseases such as hepatitis B, drugs such as entacavir and tenofovir, and hepatitis C, sofosbuvir and velpatasvir. And alcohol-related withdrawal of alcohol and treatment with benzodiazepines if necessary. Liver-protected drugs such as N-acetylcysteine are given for ascites and portal hypertension, spironolactone, and furosemide. And in cases of hepatoencephalopathy, drugs such as lactulose and rifaximin. In end-stage liver disease, liver transplant may be required. Hepatitis: it is an acute parenchymal disease of liver due to a variety of causes in which variable number of hepatocytes undergo necrosis. Two types: acute and chronic. In acute, it is the disease of liver evolving within hours, days to few weeks. 8 weeks is called acute hepatitis, whereas chronic parenchymal disease manifestations either as chronic hepatitis or cirrhosis of the liver. Clinically, chronic hepatitis is defined as any hepatitis lasting 6 months or longer. Pathology: mild liver cell injury, more severe damage, or very severe damage, inflammatory damage or liver cell necrosis, widespread damage in the centrilobular zones, lobes and portal tracts are enlarged and infiltrated with mononuclear cells, fatty change in the liver is absent, whereas PMN infiltration is not seen. In subacute bridging necrosis or more severe damage, collapse of the reticulin supporting network between the central veins and portal tracts with the result that they become linked to each other. Very severe damage or massive necrosis, acute liver cell atrophy, there is destruction of lobules, and lesion is commonly seen in patients with acute fulminant hepatitis or acute hepatic failure. Intrahepatic cholestasis may be prominent in some cases. Causes: acute consists of viral hepatitis A, B, C, D, E, Ray's syndrome in children. Non-viral, example leptospirant toxoplasma. Drug-induced, such as by paracetamol, halothane, rifampicin, chlorpromazine, pyrazinamide. Wilson's disease, pregnancy shock, or Budd-Chiari syndrome. Chronic include hepatitis B, C, D, drugs such as methyl-dopa, isoniazid, alcoholic steatohepatitis, and non-alcoholic steatohepatitis, hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, and autoimmune hepatitis. The types of hepatitis: hepatitis A and E, main source of viruses species, whereas B, C, and D are blood-derived body fluid. Hepatitis A and E spread from contaminated food or drinks, whereas hepatitis B, childbirth, contact with infected body fluid or sexual contact. Hepatitis C, contact with infected body fluid and sexual contact. Hepatitis D, contact with infected body fluid, only occurs in people who infect with hepatitis B, sexual contact. It is also known as superinfection. Acute hepatitis B, caused by hepatitis B virus or the hepadnavirus. Under EM, the whole virus is the Dane particle, which consists of an outer surface spore. The inner nucleus consists of DNA polymerase enzyme, and core antigen, and capsular or envelope antigen. The virus has been identified in most of body fluids, especially tears, saliva, and semen, and is infectious. Mean incubation period is 60 to 90 days. Symptoms of hepatitis B include fever, jaundice, dark urine, nausea and vomiting, pain in the right side of the abdomen, headache, hives, joint pain, weakness, fatigue, and losing your appetite. Clinical features include transient rashes, arthralgia, arthritis, myalgia, pneumonia, agranulocytosis, aplastic anemia or hemolytic anemia, and Guillain-Barré syndrome. Signs, as we have already discussed: fatigue, fever, muscle aches, loss of appetite, nausea, vomiting, abdominal pain, a general feeling of being unwell. Now, HPV or HCV infection can lead to chronic hepatitis, which can cause secondary events leading to cellular DNA damage, chromosomal abnormalities, genetic mutations, or viral DNA damage, integration in the host genome in oncogenic viral genes, leading to loss of cellular growth control, which can lead to hepatocellular carcinoma. Investigations. Serum bilirubin is raised by 20 mg%. Conjugated hyperbilirubinemia indicates intrahepatic cholestasis. SGOT and PT are raised 400 to 4,000 international units. If AST is more than ALT, then it is thought to be alcohol-induced. Plasma albumin may be low but is usually normal. Urine may contain excessive urobilinogen, but bile salts and bile pigments are absent in hepatitis B, whereas during cholestatic phase in hepatitis A, they may appear in urine. Prothrombin time may be normal if prolonged constitutes a bad prognosis. Serological tests include the viral markers. Now, viral markers for hepatitis B include appearance of HBs antigen in serum is the first evidence of infection. Persistence beyond 6 months signifies chronic hepatitis B. The disappearance of HBs antigen and appearance of anti-HBs indicates either recovery from HBV infection or non-infectivity or immunity. IgM anti-HBC indicates diagnosis of acute hepatitis B. Presence of HBe antigen indicates acute viral replication and infectivity. Here, the patient is most infectious. Its persistence beyond 3 months indicates chronic hepatitis B. However, appearance of anti-HBe signifies diminished viral replication and decreased infectivity, that is, indicating recovery from hepatitis. Now, hepatitis B serology. If a patient is suspected of hepatitis B infection, we test for HBs antigen. If it is positive, then it's an active infection and test for HBC antibody. IgM positive, then acute hepatitis B infection. If IgG positive, then it is a chronic infection. Check for HBe antigen and viral load for infectivity and replication of virus. If it is negative, then no active infection and test for HBs antibody. If it is negative, no immunity. If positive, test for HBC antibody. IgG positive, declared hepatitis B infection, and if negative, patient is vaccinated. Now, this is a flowchart indicating the window period, 24 to 32 weeks. We have a window period and indicating the level of HBs antigen or antibodies that are raised during the meantime. Treatment. There's no specific treatment. Barrier nursing and care should be enforced. Unnecessary bed rest should be avoided. And light diet in the form of fruit juice, soft drinks, and glucose acceptable. No specific drug therapy is advised. Prophylaxis. A recombinant hepatitis B vaccine containing HBs antigen capable of producing active immunization 95% of normal individuals is available. So injections are given intramuscularly at 0, 1, and 6 months. Larger doses are used for compromised patients. Now, hepatitis B C virus is caused by hepatitis C. It can range from mild illness lasting a few weeks to serious lifelong conditions leading to liver damage, cirrhosis, or even liver cancers. Causes and transmission include blood-to-blood contact, sharing needles, unsafe medical procedures from mother to baby, sexual contact. Diagnosis: blood test, HCV antibody test, HCV RNA test, liver function test, and liver biopsy. How it affects the body: fever, decreased appetite, weight loss, gastrointestinal issues, jaundice, joint pain, dark urine, and fatigue may be seen. Treatment and prevention: modern antiviral antibiotics, medications, sofosbuvir, ledipasvir, vilpatasvir. Prevention: avoid sharing needles, use sterilized equipment for tattoos and piercings, practice safe sex, and screen blood donation. Chronic hepatitis B is a long-term infection of the liver caused by hepatitis B virus, which can lead to liver damage, cirrhosis, liver failure, or even cancer. Symptoms include most people with chronic B have no symptoms for years, whereas some symptoms are fatigue, jaundice, dark urine, abdominal pain, nausea and vomiting, swelling in legs or abdomen. Diagnosis: same as acute hepatitis B. Treatment: chronic hepatitis B. If hepatic compensation is seen, then HBe antigen positive and HBe antigen negative. The treatment varies. Whereas in decompensation, liver transplantation, immunosuppression, lamivudine, and other approved nucleotide analogs for lamivudine resistance. Cirrhosis: it includes a triad of degeneration of hepatocytes, regeneration, hyperplasia of remaining or surviving hepatocytes, and fibrosis. Pathologies of three types: micronodular, macronodular, and mixed type. In micronodular, also known as Linac cirrhosis, the regenerating nodules are small and every lobule is involved, whereas large nodules seen in macronodular and irregularly placed normal lobules, hence liver architecture is disturbed, also known as the post-hepatic or post-necrotic cirrhosis. In mixed type, both types are seen. Common etiologies include inflammation, viral hepatitis B and C, schistosomiasis, autoimmune types 1 to 3, sarcoidosis. Toxic include alcohol or drug use such as methotrexate, Congenital include primary biliary cirrhosis, alpha-1 antitrypsin deficiency, hemochromatosis, non-alcoholic fatty liver disease, Wilson's disease, congenital heart failure, veno-occlusive disease such as Budd-Chiari syndrome, and unknown causes. Types are alcoholic cirrhosis, also known as Linac cirrhosis, post-necrotic cirrhosis or post-hepatic or post-viral cirrhosis, biliary cirrhosis, cardiac cirrhosis, metabolic or hereditary cirrhosis. Shown are stages of liver damage. Healthy liver transforms to a fatty liver due to increased fat deposits, transforms to a fibrosis liver, the formation of scar and tissue of the liver, liver cell destruction leading to cirrhosis of the liver. The signs and symptoms include fatigue, easy bruising or bleeding, itchy skin, jaundice, ascites, loss of appetite, nausea and vomiting, edema, hepatic encephalopathy, unexplained weight loss, spider telangiectasia, redness in the palms and hands. Investigations. SGOT and SGPT levels are low in established cirrhosis but increase in evolution. Low levels of serum albumin indicate cirrhosis. Plasma bilirubin is normal in most cases but increase in decompensated cirrhosis. Anemia, leukopenia, and thrombocytopenia or pancytopenia may be seen in cirrhosis. Ascites develop in cirrhosis due to hepatocellular damage and portal hypertension, and IOT is transient in nature. Serum albumin and ascitic fluid gradient more than 1.1 indicates raised portal vein pressure. Complications of cirrhosis are portal hypertension, hepatic encephalopathy, hepatorenal syndrome, increased incidence of HCC, pulmonary septicemia, fatal bleeding, spontaneous bacterial peritonitis, malnutrition, and hypersplenism. Treatment. If there is cirrhosis, then it's stable. Moderate for end-stage liver disease score is less than 15, then monitor for complications. If not, then monitor for complications. Surveillance for varices is done, ascites, hepatic encephalopathy, and screen for HCC. Coming on to kidneys. The kidneys are V-shaped organs located on either side of the spine in the retroperitoneal space of the upper abdominal cavity, positioned between the T12 and L3 vertebra. Have two main regions, outer and outer cortex and inner medulla. Outer cortex consists of the filtering units known as nephrons, whereas inner medulla contains pyramids that help in urine collection. The outer structure consists of venous capsule, which is a tough fibrous covering protecting the kidneys, and retinal hilum, a concave area on the kidneys inner side where blood vessels, nerves, and the ureter enter and exit. Nephrons are the functional units of the kidney. Each kidney has around 1 million nephrons, and parts of nephrons include glomerulus, Bowman's capsule, and the tubules, proximal loop of Henle, distal, and collecting duct. Kidneys are supplied by the renal artery from the aorta and drained by the renal vein. A diagram showing the renal kidney anatomy. 5 key functions of the kidney include making strong bones. They convert vitamin D to the active form. This increases the calcium levels in the bone, excreting waste into the blood. The kidneys act as a filter in small molecules, pass through the glomerulus into the urine. Damaged kidneys allow proteins to escape. Controlling blood pressure. The kidneys monitor blood pressure in the juxtaglomerular apparatus. If it is falls, then renin is produced in the kidneys to raise the BP, boosting the production of red blood cells by the secretion of hormone erythropoietin. It stimulates the bone marrow to manufacture RBCs. It balances levels of salt and water. They monitor and manage the concentration of water and salt, respond to two hormones, antidiuretic and aldosterone, which affect the reabsorption of water back into the body. Common urinary symptoms are polyuria. It is the excretion of 3.0 liters of urine daily, provided patient is not on high fluid intake. Causes are as follows. Drugs, example, chlorpromazine or anticholinergics, diabetic insipidus, nephrogenic causes, congenital or tubular interstitial diseases, chronic renal failure, diabetes mellitus, and diabetes. Dysuria is pain or burning during micturition. Urgency of micturition is the exaggerated sense or urge to micturate due to inflammatory disorders of urinary bladder. Incontinence is inability to retain urine in bladder. Some causes are cerebrovascular accidents, dementia, postmenopausal parasomnia, etc. Enuresis, involuntary passage of urine at night or during sleep, also called as night bedwetting or nocturnal enuresis. Oliguria refers to urine output less than 500 ml per day in an average adult, whereas anuria is when a patient does not pass urine up to 50 ml in a day. Disorders of kidney are nephritic syndrome, also known as acute glomerulonephritis, nephrotic syndrome, and the renal failure. Coming on to acute glomerulonephritis, it is a disease that involves mainly the glomeruli and to a lesser extent the renal tubules by an acute transient inflammatory process, manifests clinically by acute reduction in GFR, rapid renal failure, proteinuria, and salt and water retention. Inflammation of the glomeruli and of the small blood vessels is seen in glomerulonephritis. Clinical features include hematuria, red cell cast typically seen in urine, proteinuria less than 3 grams per day, not in nephrotic range, puffiness of the face, fetal edema, and hypertension due to salt and water retention. Oliguria is a marked feature, and uremia, that is raised urine creatinine. Symptoms are blood in the urine, hematuria, proteinuria, abnormally high levels of nitrogen-containing substances, also known as azotemia, low output of urine, oliguria, hypertension, and blood vision. Causes: post-streptococcal glomerulonephritis. Non-streptococcal glomerulonephritis include causes such as hepatitis B, echovirus, malaria, infective endocarditis, staphylococcal and pneumococcal infections. SLE, vasculitis, Goodpasture syndrome, mesangiocapillary glomerulonephritis, serum sickness, and DPT vaccine. Investigations and findings: in urine microscopy, RBCs in red blood cell casts are seen. Urine complete specific gravity is taken into account, whereas high proteinuria is present. Blood urea and serum creatinine may be elevated. A culture done for nephrogenic streptococci not always present. ASO titer elevated in post-streptococcal nephritis, whereas C3 level is reduced. Antinuclear antibodies present with significant titer in lupus nephritis. X-ray test shows cardiomegaly. Pulmonary edema is not always present. Renal imaging is usually normal, whereas renal biopsy shows glomerulonephritis. Management is directed to control the symptoms till this is resolved. Patient should be hospitalized if rest is advised. Daily record of fluid intake, output, weight, and BP to know circulatory status and avoid fluid overload. Streptococcal infection is to be treated with penicillin. Salt-free and low-protein diet, diuretics to control edema, hypertension controlled by ACE inhibitors, and dialysis may be required transiently. Complications include hypertensive encephalopathy, acute left heart failure, non-cardiogenic pulmonary edema, and uremia. Nephrotic syndrome refers to massive proteinuria more than 3.5 gram per day, mainly of albumin. The thing to notice, there was proteinuria seen in nephrotic syndrome also, but the level ranges less than 3.5 gram per day, whereas in nephrotic syndrome, it exceeds 3.5 gram per day. Massive proteinuria alone is sufficient to describe the syndrome. As we can see in normal, the blood and waste and the filtered blood, protein is not leaked, whereas in nephrotic syndrome, the protein is leaked into the urine. Constituents of nephrotic syndrome include massive proteinuria more than 3.5 gram per day, hypoalbuminemia, that is the main protein that is excreted is albumin. So albumin levels are less than 3 gram per cent, pitting edema, facial puffiness, hyperlipidemia and lipiduria, coagulopathy, hypertension may or may not be present. Idiopathogenesis: any podocyte injury due to drugs, immunological, mechanical injury, or genetic predisposition leads to distortion of podocyte skeleton, effacement of podocyte foot processes leading to podocyte detachment, causing podocyte depletion or loss, leading to impaired glomerular filtration rate, which can cause nephrotic syndrome. Causes: primary causes include minimal change nephrotic syndrome, focal segmental glomerulosclerosis, membranous nephropathy, IG nephropathy, membranoproliferative glomerulonephritis, or hereditary causes. Secondary causes include systemic disease such as diabetes, lupus, infections, preeclampsia, certain drugs and toxins, and congenital. Signs and symptoms: edema that begins in the face, tachycardia, vomiting, proteinuria, hyperlipidemia, pale skin, and tissues. Investigations: urine examination reveals proteinuria and cast. Hematuria is uncommon. Oval fat bodies may be present. 24-hour urine shows excretion of albumin or proteins more than 3.5 gram per day. In early stages or in patients receiving treatment, proteinuria may be less. Serum lipids show increased LDL and cholesterol. Serum proteins may show hypoalbuminemia. Renal function tests are normal. Ultrasound of abdomen may show normal, small or large kidneys depending on the cause. Amyloid and diabetic kidneys are large, while kidneys in glomerulonephritis are usually small. Renal biopsy to predict prognosis and response to treatment. To determine underlying cause, serum complement tests, serum and urine protein electrophoresis, antinuclear antibodies, and serological tests for hepatitis should be run. Treatment includes relief of edema. Patient advised to take low sodium diet, usually 1 to 2 gram per day. That is a no added salt diet. If it is mild, thiazides may be used in moderate loop diuretics. To avoid hypokalemia, loop diuretics paired with the spironolactone. Salt-free albumin or plasma albumin infusion is done. Control of proteinuria. Protein should not be restricted unless GFR falls less than 25 milliliter per minute. ACE inhibitors, ARBs, and NSAIDs are used as protective agents. Treatment of hyperlipidemia: it does not require treatment except dietary restriction and exercise. But when serum cholesterol is more than 500 milligram, then lipid-lowering agents such as atorvastatin 20 milligram once or twice a day is employed. Immunosuppressive therapy with corticosteroids for 6 to 8 weeks, and focal glomerulosclerosis and presenting glomerulonephritis show poor response. Control of infection, anticoagulants, and treatment of the underlying cause. Diffuse endocapillary proliferative glomerulonephritis is a severe form of glomerulonephritis in which there is marked proliferation of mesangial endothelial and epithelial cells. There is diffuse inflammatory cell infiltration at the site of involvement. Immunofluorescence microscopy reveals deposition of fibers, C3 and immunoglobulins at these sites. In some cases, there is formation of crescentic glomerulonephritis. Treatment is symptomatic. Infection is treated with antibiotics, antihypertensive drugs to control hypertension. Diuretics may be used to relieve edema. Mortality is high. Difference between a nephrotic and nephritic syndrome, as we already discussed. Renal failure. The deterioration of renal functions resulting in decline in GFR and rise in urea and non-nitrogenous substances in blood is called renal failure. Types include acute, develops over days or weeks, chronic, develops over months or years. Renal failure's features are acute include sudden onset, higher chance of reversibility, no stunting, slight anemic, normal size and large kidneys, heart may not be enlarged. Whereas chronic include insidious onset, lesser chance of reversibility, severe anemia but with signs of compensation, hypertension, stunted, small kidneys by ultrasound, enlarged heart, indicating left ventricular hypertrophy. Acute renal failure is defined as a sudden, usually reversible deterioration of renal functions developing over a period of days and weeks with rapid rise in blood urea. Characteristic features include marked reduction in urine volume, acid base, fluid and electrolyte disturbance, could be prerenal, renal, postrenal, can be oliguric or non-oliguric. Oliguria in a patient with chronic renal failure is called acute or chronic renal failure. Causes prerenal include blood loss, dehydration, heart failure, sepsis, vascular occlusion. Intrinsic include drugs, toxins, prolonged hypotension, glomerulonephritis, acute tubular necrosis, drugs, toxins, autoimmune disease, infections, small vessel vasculitis. Postrenal include benign prostatic hyperplasia, cervical cancer, meatal stenosis or phimosis, retroperitoneal fibrosis, prostate cancer, and urinary calculation. Now, some of the risk factors which may transform acute into chronic kidney disease are age, race or ethnic group, genetic factors, hypertension, diabetes mellitus, metabolic syndrome, leading to outcomes such as cardiovascular events, kidney events, end-stage renal disease, disability, diminished quality of life, and death. Symptoms of acute and chronic renal failure differ, such as acute includes reduced urine output, swollen legs, ankles, and feet, weakness and fatigue, high blood pressure, confusion, and chronic include abnormal blood and urine tests, swelling in the face, hands and feet, headaches, high blood pressure. Diagnosis is based on no previous history of pre-existing renal disease in case of ARF, presence of oliguria and anuria, symptoms and signs of uremia with rapid rise of blood urea and creatinine. The intrinsic renal failure, also called as the acute tubular necrosis, passes clinically through three stages, oliguric stages. During this phase, patient passes less than 500 ml of urine per day. It contains proteins, casts, and cells. During this period, symptoms and signs of uremia appear. There is danger of development of life-threatening complications, and the treatment is likely mainly towards keeping the patient alive, which includes treatment of hyperkalemia, finding out the cause and treating it, control of hypertension, renal protection, water and electrolyte balance, treating infection, and metabolic acidosis. The diuretic phase during this period, patient passes large amounts of salutary urine, 3 to 5 liters per day for 3 to 5 days. On an average, 3 grams of penicillin and 2 grams of NaCO3 are needed for 1 liter of urine passed. As renal functions improve and blood urea falls, the patient can start normal diet. In recovery phase, after a period of 7 to 20 days, recovery takes place and all parameters of renal dysfunction disappear. Treating ARF, we treat the predisposing disease by antibiotic surgery and decrease inflammatory and stop nephrotoxic drugs. Intravascular volume expansion is done by crystalloids and diuresis. If CVP is low, then more volume expansion. If CVP is normal or high, then FBP is checked and doses of furosemide are given. Chronic renal failure defined as kidney damage with a functional structural with decreased GFR, that is 60 ml per minute persisting of more than 3 months. Albuminuria, decreased GFR are its hallmarks. Pathogenesis include progressive destruction of nephron loss, and CKD leads initially to compensatory hypertrophy of remaining surviving nephrons. It passes through 5 stages, and stage 4 is designated as renal failure, whereas 5 is end-stage renal disease. Causes include tubulointerstitial diseases, focal glomerulosclerosis, membranoproliferative glomerulonephritis, amyloidosis, diabetes mellitus, hemolytic uremic syndrome, osteoinfectious glomerulonephritis SLE, hereditary nephritis known as Alport syndrome, medullary cystic disease, nail patella syndrome, benign prostatic hyperplasia, posterior urethral valves, etc. Now, symptoms of CKD are pallor, breathlessness, altered cognition, anorexia, taste disturbances, unemic breath, polyuria, oliguria, nocturia, proteinuria, hematuria, periodema. Risk factors are diabetes, autoinflammatory diseases, infections, demographical and genetical factors, age, gender and family history, childhood and adolescent states and diseases, premature birth, treated childhood cancers, etc., and lifestyle factors such as smoking, low physical activity. Clinical patients for adults with chronic kidney diseases, anemia is checked, malnutrition, mineral and bone disorder, alkaline phosphatase levels, calcium and phosphorus levels, and parathyroid hormone levels, neurotherapy for paresthesia, mental status, sleep disturbances, sleep studies are done, reduced level of functioning and well-being is checked. Potential treatment for CKD includes colonic dialysis, vitamin D supplementation, phosphate binders, regular consumption of medication, charcoal absorbance, prebiotics and probiotics, dietary fiber intake. Comprehensive care includes immunization, judicious use of potentially toxic medications, lipid management, BP management, weight, glycemic control, plant-based diet, physical activity, genetic testing for kidney actionable genes, and counseling regarding the risk. The risk factors for kidney failure, that is end-stage renal disease, include older age, proteinuria, DM, elevated blood pressure, elevated serum creatinine levels, obesity, smoking, oxygen exhaust, etc. In conclusion, the gastrointestinal tract, liver, and kidneys play vital roles in digestion, metabolism, detoxification, and waste elimination. A healthy diet, hydration, and lifestyle choices are essential for their proper functioning. Understanding these organs helps in early disease prevention and overall well being. Maintaining their health ensures the body's efficiency, just as well functioning system ensures smooth operations. These are my references. Thank you and have a wonderful day ahead.